Welcome to DocPod. Hear Health.
So I'm here with Dr. Mark Trolice, who is the founder and director of the IVF Center in Winter Park, Orlando, Florida, who is also a board-certified reproductive endocrinology and infertility specialist. So Dr. Trolice, thank you so much for coming on the show.
My pleasure to be here, Jeremy. Thank you for the invitation, and I'm looking forward to a great discussion.
As am I. I wanted to touch on a few different things within IVF, and this is, a 30-minute chat or window we have. So future episodes, of course, and probably not going to have nearly enough time to cover everything that we should. But a few things, one of which I'm particularly interested in is I saw that you were recently a panelist in an AI in ovarian stimulation webinar. And, when I think of AI, and I know its implications in healthcare with workflow and EMR and charting, and some of which in wearable devices, things like that. But in IVF, I'm curious as to what that application is, how you see it now and moving forward in the future, the improvements it can provide, et cetera. So you can talk to me a little bit about that?
Terrific question, Jeremy. Artificial intelligence is not the future, it's now. Tremendous number of applications that are coming out to ease the burden of some less intensive work that needs to be done on a regular basis, but also to assist the clinician in decision-making. The big data that's being used is allowing clinicians to be able to make decisions on patients with real good data to support that recommendation. We use a program with our partner in Israel that looks at an IVF cycle and will actually give us a recommendation of when to employ what we call a trigger injection to get the eggs ready to do the egg retrieval. It's really been great. It also gives us a tool that predicts how many eggs we would get. And we're looking into another tool that's giving us dosage of medication. So that's the clinical side. And we're also looking at how that's impacting live birth rate. Not all of these tools are giving us the live birth rate, which is the holy grail of everything that we do. We want baby. But it's also making our ability to advise our patients just that much stronger. The second is in the laboratory. I was just on a call yesterday and using a method called time-lapse microscopy, where we look at the embryo from the moment the egg is fertilized by the sperm, all through its development, giving us information on what is a better quality embryo. And the hope is that that's what's going to get us to a better embryo identification to improve outcome of cycles. Preliminary evidence is showing that it is getting to the better embryo sooner, and it reduces the burden on the embryologist from doing less expertise tasks so that they can focus on the ensuring the quality control of our laboratory. Amazing visualization of the embryo that patients can actually log on to and look at their embryos being developed over the time they're in the lab. So It's really remarkable, and it's only going to get bigger and better.
So not only is it advantageous in the predictive analytics where you're able to treat or prescribe treatment to a patient by understanding where exactly their cycle is, how many, but also the quality. So I have to think that makes your job a lot easier, or maybe that's the wrong way to put it. You're able to be as specialized as you were trained for, so as to take all of the analytics out of it. And obviously there's human element to it, so it's not fully trustworthy. But to be able to do what you do and make sure that data is implemented into this particular patient's situation, and then ultimately a better outcome of live birth.
Well, that's the goal, right? No matter what we say and do in our world, all the metrics that we look at are secondary to did she get pregnant and deliver a baby?
Mm-hmm.
That's what we care about the most. The interesting thing about what we do with artificial intelligence is that we at least get more support for the decisions that we're making. Mm-hmm. And in the clinical area, as well as the laboratory, amazing developments that are going on so that we can get to the better embryo sooner to show that there is evidence, and we don't have this definitively yet. There's a technique that's being used that we've used for years that we could remove some cells around the embryo called pre-implantation genetic testing. And you do a chromosome analysis of the embryo. Well, that isn't the only reason why an embryo doesn't implant or implants. But what we need to know, the data hopefully comes out, is that whether the visualization of embryo development and all of the analysis that we look at, is that going to be equally effective, or at least not inferior to removing cells around the embryo? So there's still a lot of work to be done. But to your point, there's an art to medicine, and we don't relinquish that control to machine learning, right? But the art, ironically, ART is assisted reproductive technology, which is IVF. But this is sort of a partner with us, and we look to them for some recommendations, but ultimately the physician experience is always going to be superior. Now, an interesting thing about the embryology laboratory is that these studies have shown that there is so much variability in grading an embryo's appearance among embryologists. It's really a coin flip. Whereas with the embryo time lapse in microscope, you're able to get more objective scoring of these embryos that can only improve outcomes.
Well, and I have to also think that, and I've had friends, several actually, that have gone through IVF treatment, and the first time didn't take, the second time didn't take, third time it did, or even sometimes more, or sometimes in the first. So there's a lot of variance between when live birth occurs and when it does not, and it's very obviously patient specific and scenario specific. But I have to think that all of the data that is available and being analyzed in real time and faster than that allows a lot more comfort and maybe efficiency for the patient and the physician, respectively.
An instrument that we looked at yesterday gave a preliminary data on observation by the embryologist as to which was the best embryo to transfer versus the artificial intelligence platform. And this was retrospective, which means that this was all done and they looked back at the data. Well, when the patient, when we looked at with use of artificial intelligence, the platform used the embryo that would have resulted in a pregnancy. They chose that embryo first. And when you looked at patients who did not conceive, they had such a higher pregnancy rate when they went to the embryo that did result. The artificial intelligence recommended that one first. So it's a very exciting, robust technology. Has to be used appropriately and judiciously, but I think that it's only going to improve the care that we can give our patients.
I mean, that's unbelievable. I'm curious, and this is maybe just a random question, but do you think that if with all of these developments in AI and what we're talking about right now and being able to select the perfect or the most viable egg and make it so that it is that much more inaccurate of a process, do you think, maybe this is a twofold question, that that will motivate more people to pursue IVF, and B, potentially have people pursue IVF over maybe natural sex or whatever, right? So, and I say that because, you have, single men, women now that want to have children, et cetera. And so in those types of scenarios, do you think that one may lead to the other?
That's quite the loaded question there, my friend.
I don't know how loaded it is, but
No.
answer at your will.
Well, I was going to segue into an area that is I'm very passionate about, and that has to do with the risk of exploitation of patients with infertility. We do not have enough insurance coverage to make access to care equitable. Unfortunately, our field has been infiltrated with business and private equity that I don't feel is ultimately in the best interest of patients and probably not in the best interest of physicians. When they are buying physician practices, the physician gets a windfall, as it were, but then they really relinquish control. Physicians are not business people, and neither business people are physicians. And there needs to be, if there is going to be a merger, if you will, we need to stay in our lanes. So all that introduction was the fact of, are more people going to be doing IVF? Well, here's the problem with that, Jeremy. There's more IVF cycles every year, but success rates aren't getting better. There's more IVF cycles every year. The cost is going up every year, and the success rates aren't getting better. So what's wrong with this picture?
Right.
What's wrong with this picture is that, unfortunately, there is increasing encouragement for patients to enter IVF, which I would argue prematurely. Rather than going through more conservative measures that may take a little bit longer but are less expensive, I see it firsthand on a regular basis. Patients are being encouraged to go to IVF. And I think prematurely, at least the patients that I'm seeing and from what I'm hearing. Until and unless IVF is 100% successful, it's very difficult for me to tell a patient, hey, I think we need to go to IVF. Or that's your only option. Or encouraging them and downplaying the more conservative approaches. In medicine, our ethic was to start off with the most conservative and then to go the most aggressive treatment appropriately. But to, lack of a better term, push IVF prematurely is not in the best interest of the patient. It's really in the best interest of revenue and pockets.
Right.
So I'm very passionate about ensuring the protection of patients. Access to care doesn't necessarily mean that they need to be able to go right to IVF. The way you get access to care is to make the cost of IVF more in tune with the ability for patients to afford. I just have difficulty with the increasing costs of IVF, increasing cycles of IVF. Yet over the last 10 years, if you look at the data from the Society for Assisted Reproductive Technology, there is no increase in live birth rate for women less than 35, close to 10 years. So why are costs of IVF going up? Well, the worry is that people are investing in more technology that is not necessarily improving outcome. Okay? So the reason that costs may be going up is that the clinic now has made a significant investment and they're looking for an ROI. Okay? But to me, that's an investment that the clinic has to make that's going to definitively improve the outcome of the patient. And if not, I don't think this should be passed on to the patient.
Right. It needs to there needs to be a little bit more altruism involved there, I would assume.
Well, it's fairness. I don't know about necessarily altruism. If you're trying to improve the ability for the patient to have their goal of a live birth, and IVF is a significant financial burden on patients, right? It's difficult for me to pass along to the patient unless you've been shown to have a better outcome. And what's a better outcome? There is only one better outcome.
Right.
Live birth. Everything else, well, you got more embryos with this cycle. Or we were able to show which embryos were chromosomal or not. Okay, that's all good. And that's great for research studies and presentations at meetings. Patients want live birth.
Right.
That's all that matters.
I mean, you can put as much food as you want on the table, but if you can't eat it, what's the point? Right. So, you spoke about jumping straight into IVF, which is seldom recommended wisely, from your point of view and opinion. I think that's valid. So what would be some of those more conservative paths that one could take prior to going to IVF that you've seen, that you've recommended? Maybe just a brief and high level overview.
Well, the first thing to do is to ensure that you don't tell the patient what to do. There are options of natural conception. There are options of intrauterine insemination, and there are the option of in vitro fertilization. It is a dialogue with the patient of how much of a physical, emotional, and financial investment they want to put into this. So how do you optimize natural conception? Well, if you're speaking with the patient and she's never using an ovulation prediction kit, knows that when's the optimal time for pregnancy, then it's reasonable to address that and say, maybe you need to go a few more months of trying naturally, which I've done multiple occasions of patients have come back to me, thanking me for not giving them the lecture, if you will, about going on more aggressive treatment. Our goal as reproductive endocrinology and infertility specialists really is to help them conceive naturally. And if that's been exhausted or poor prognosis, then we step it up. And how do we step that up? Well, what about surgery if tubes are blocked? Not severely, of course, but if there are things that could be done, removing endometriosis, which is the disease that affects infertility patients. IVF, unfortunately, is the hammer and nail syndrome, right? If a physician loves to do IVF, then they're really going to recommend probably IVF more soon. And to me, if you're going to put a thumbtack in, you'd use your thumb, not a jackhammer. When it's appropriate, IVF is a terrific tool, very, very well described, has helped myriad number of patients since its inception in 1978. But I don't think it's appropriate to be recommending IVF until other areas have at least been discussed as options for patients. Now, granted, intrauterine insemination is not a high success rate, but it's a lot less successful, and patients conceive with intrauterine insemination. I give them statistics. I do not give them telling them what they need to do. I have a calculator on my desktop from the Society for Assisted Reproductive Technology that gives the option of the data of up to 3 cycles of IVF and the live birth rate. And that's used because SART is the society, and they have 90% of clinics using their society to report their data to the CDC. By the way, we're the only specialty in this country that has to report by law their pregnancy outcome data to the CDC.
Really? Let me pause you there. Why? Or how, yes. Maybe? How is that possible?
That's what I ask you. Why? Cardiac surgeons, neurologists, bariatric surgery pay. Nobody else has to report their data. Why does trying to help patients build family have to report their data to the CDC since the early 1990s? I don't know what drove that process, whether it was politically motivated, religiously motivated. We're just helping people have babies. But maybe it seems to be a trigger for a lot of issues that we've just had to deal with in this election, right?
Well, it sounds like it, but I would ask you have there been any negative and or positive repercussions for the reporting of that data? Like, has anything happened to anyone based on whatever data that was, whether it's good or bad, or does it do anything, or is it just hey, this is kind of an inconvenience just for you?
I think it was actually the death knell of collegial relationships when data was made public, because then all of the goodwill that we had made us competitive.
Right.
And now IVF centers are tremendously competitive amongst each other The advertising, not always accurate, somewhat misleading, and it's become very much revenue driven as well. And I think it was started the demise of evidence-based medicine and getting involved in now what can we do to increase cycles. There's egg freezing. Egg freezing has become such a hot topic. It increased dramatically the numbers of patients that are doing egg freezing. I'm just more of a purist. I have difficulty doing a lot of dangling the baby carrot out there. I think that patients need to make these decisions for themselves, but I think it was a big mistake that required IVF centers to report their data, because then it became open field for making patients think that one setting was better than another, when really, unfortunately, different patient populations could affect statistics.
And data without context is probably not anything good for an uninformed data consumer to take a look at and make a decision on.
Yeah. And STAR has done a terrific job in trying to keep this in control. They have an advertising committee that when websites of physician practices are misleading or against guidelines, the practices are called, and they risk membership law if they're not being compliant. So we do the best we can, but I don't think it was in the best interest of patients or even clinics in our field to be putting that data out there. Not because we want to withhold that and be misleading, but the fact that public awareness of the clinic's data then made clinics rush to try to improve their statistics through some studies and published studies that people have questioned till now as well. But then you're getting into, I have to start offering this technology because that can only potentially help, or I have to at least make patients know that I'm offering this. The ethic of physicians with integrity. What's integrity, right? Doing the right thing even when no one's looking. Our ethic is to do the right thing with our patients, is always primary and never influenced by revenue. Unfortunately, the multi-billion-dollar industry of reproductive medicine has changed things, and it has made a conflict of interest. And I said this on another podcast, and I was challenged by that. When physicians own the lab that is charging patients for the IVF cycles, and it is a significant amount, it is an inherent conflict of interest. It doesn't mean that the physician is exploiting the patient, but there is the risk that we have to always abide by that solemn oath, that we are not pushing a procedure because we're getting the revenue from that procedure higher than anything else.
Right. And why not just remove all temptation, even if, it's not acted upon, it's still the opportunity is there. It's like when a software developer tests his own code, right? It's just, it doesn't work out well because obviously it's going to be approved. So,
this is the impetus for my pursuit of obtaining accreditation for a fellowship training program in reproductive endocrinology. We're very, very proud of that. One of about 50 programs in the country. And so we teach medical students, residents, and now fellows in the field of reproductive endocrinology and infertility. It is an honor, a privilege, and it's a legacy, really, because I wanted to ensure that they're being taught in a way that will treat patients with the depth and breadth of our specialty and not influenced by anything else.
Well, and I think also, it's easy to get fired up about this. I think if you have any semblance of a soul, because IVF is one of the more sacred specialties in all of medicine. Now, all physicians have taken the Hippocratic Oath, right? Do no harm. But IVF, you're starting families. You're giving people the opportunity to procreate, but to raise their children that they otherwise could not have or may not have. And I've the joy in my friends' lives when they had twins, when they had been trying so very hard to have one, and they were elated. And I love their little boys. I hang out with them all the time. And I knowing that joy that came to them, multiplied by millions, if you add anything else into it that taints that process, you're doing yourself, you're doing the patient, you're doing the world, I think is a little hyperbolic, but a disservice. And
well, another disservice, and I'm a reviewer for a medical journal. And yesterday I was reviewing a paper about how to implement gynecologists, not fellowship trained, mind you, but gynecologists into IVF clinics to help with the load of patients and increase access, what they called access to care, which I have to take umbrage against, because access to care should be equitable care, not having non-fellowship trained physicians be an adjunct or being another arm, if you will, of the armamentarium of the reproductive endocrinologist. We are not, or those that don't have a fellowship program, are not accredited to train other physicians to do the specialty of reproductive endocrinology and fertility, REI. Mm-hmm. And to add gynecologists is a disservice to patients. So you're not, you're putting under the guise of access to care, but you're really just increasing your revenue by seeing more patients that you have a limit to see from the time of the day, but now you're having other physicians see the patient. Patients don't always know the difference. Right. And they deserve that we uphold that obligation to provide them with a board-certified REI, as opposed to a gynecologist who has no formal training in the field. But unfortunately, that's what's happening. And that's the exploitation, and that's where business gets involved in medicine, and it's just wrong.
Well, he mentioned in that last statement that patients don't always know the difference. I didn't and wouldn't know the difference. Granted, I've never seen a gynecologist, but that said, I was none the wiser until about 5 seconds ago. And that's what this platform is for, is to be able to educate people so that when they may go see an REI physician, that it is in fact fellowship trained, board certified in that specialty specifically, because you mentioned you're not seeing the specialty that you need, so you're not getting the training that they needed, and ultimately the care that you need.
I agree.
Well, I tell you what, Dr. Trolice, I've probably got another 3 to 4 hours worth of information I want to go over with you. So I'd love the chance to meet with you again. I've really appreciated the time here. Thank you so much for sharing it with me, and we'll look forward to potentially meeting with you again soon.
My pleasure, Jeremy. I enjoyed this very much, and I'm looking forward to future opportunities.
Thank you, sir. Talk to you soon.
So long.